This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to the Neurology podcast this week. Today we have Dan Weintraub joining us. You might recognize the name because we had Dan join us about a year ago. He spoke with Jeff Ratliff discussing this paper that we're going to talk about in just a minute. Dan is a geriatric psychiatrist with a special focus in Parkinson's disease and neuropsychiatry. He's at the University of Pennsylvania, and this article that he spoke with Jeff about was published in August of 2024. The title of the paper was Long-Term Dementia Risk in Parkinson's Disease, and he had a podcast with Jeff that same month that came out that I encourage you to listen to. We asked Dan to join us again today to talk about some of the clinical, practical considerations when talking about cognition in the clinic with patients with Parkinson's. So, Dan, thank you for joining us. We really appreciate it.
Thank you for the invitation, Jason, and it's a pleasure to be here talking about this important topic.
So we're not going to dwell too much on the paper from last year, but this was a paper that you and your co-authors looked at some data sets from the University of Pennsylvania and from the Parkinson's Progression Markers Initiative data set where you took a second glance at the risk of dementia in Parkinson's. Can you just briefly summarize for us what you all found?
So it's interesting in that people have assumed for quite some time now that the rates of dementia and Parkinson's disease long-term may be 80% or higher, so near universal. But the studies that underpin that or make that argument are quite old and limited at this point. So we took this as a fresh chance using two current studies that are relatively large and with good methodology to re-examine this topic. And what we found, particularly in the PPMI cohort, was that the rate of dementia long-term was much lower than had been reported previously. Only about 10% of the PPMI participants, that's a Fox Foundation-funded study following patients from disease onset forward, only about 10% of them had developed dementia by year 10 of the study. And even in our Penn cohort, where the long-term prevalence was about 75%, it took longer for patients to become demented that had been previously reported. So we took that to be a promising sign for Parkinson's disease compared with the previous literature. And the only other thing I'll say about that study, because I know we don't want to focus too much on it, is we did confirm what had been reported previously, that increasing age at the time of Parkinson's diagnosis, male, sex, and lower education level predicted development of dementia. So that does make our research consistent with previous research. And again, we feel confident in our results because we do feel like we had very strong methodology in our studies.
There's a lot of concern about individuals with Parkinson's who they're concerned about their cognition. I find that it's often one of their greatest fears. Firstly, is that something that you experience as well? Do you find that a lot of folks with Parkinson's who aren't even necessarily having a lot of cognitive symptoms have a great deal of concern about that?
I do. I think that's present from the time of onset for many patients, and if not for the patients, then for their family members. And it's interesting, it's often framed not as a question about whether I'm going to develop dementia long term, but they'll often ask me if I'm going to develop Alzheimer's disease long term. So I think they associate the dementia with having Alzheimer's disease, actually not necessarily thinking that Parkinson's disease patients can also develop dementia in its own right. But I do think maybe because of what they've heard about Parkinson's disease, or they may see a Parkinson's patient and think that some of the motor symptoms also is indicative of poor cognition, that there's a lot of assumptions, even from the time of disease diagnosis, about what the long-term course is going to be. A lot of worry, I would say.
The conclusions I would reach from the paper that was published last year is that there is some reassurance to be had from the data that you all looked at. And obviously, we don't want to offer patients false hope, but do you have any pearls when you're talking to patients that you would recommend that would, both acknowledge their concerns, which are legitimate, but also to offer them some hope or some reassurance?
We all have our own tricks, and I guess based on my experience now over many years with many patients, I do let them know that it's not uncommon to have minor cognitive changes, even at the time of disease diagnosis or disease onset. And those are most commonly in areas such as word finding or attention problems. But those are usually, even if they're noticeable and maybe bothersome, they're usually not disabling. And they also may not herald a worse long-term course. There's some evidence that those minor changes early on don't necessarily progress or don't necessarily indicate that you're going to develop dementia long-term. So I think that allows patients to feel comfortable and not so worried about having some minor changes early on. I think the variability or heterogeneity, whatever the word is we want to use, within Parkinson's disease is such that I tell patients it's really impossible for them to predict or for us to predict with good certainty about how their course is going to be. Many patients we see have intact cognition long-term, and by long-term I mean 10 years, 15 years, 20 years. And of course there are people who progress cognitively sooner than that or more severely than that earlier in the disease, but that's not so common and it's really not predictable. And so I think I do use this paper that we published as support for that maybe some of the research we had before is such that it's not as common as we once thought. And it's also important for people to remember that dementia is not uncommon in the older patients in the general population or older people in the general population. So if by the age of 80 to 90, close to half of the population has some form of dementia, then maybe that's indicative that it's not just the Parkinson's disease contributing, but Alzheimer's disease, comorbid vascular disease, other things that may be happening. So it's not just Parkinson's disease as well.
Do you routinely quote them some statistic? And if so, is it one of the numbers from this paper? Like if they say, what's my risk? Do you get into numbers or no?
Tend to not do that. I mean, not that I would have any or should have any objection to doing that, but I feel, for instance, our paper is one set of data from two studies, and I would never assume that's a definitive answer. So I tend to couch it more generally, which if somebody was to ask me that it was assumed or has been assumed for many years now that dementia is near inevitable in Parkinson's or 80% or higher long term. And I say now there's more recent studies that suggest that that number may be either lower overall or it may happen over a longer period of time than we once thought. And I did have another thought about in terms maybe comfort for patients that escaped me before. So if I'll interject it here is that the other thing I tell patients, and this is about their Parkinson's disease generally, not necessarily specifically to cognition, but I think it applies to cognition, is that if you were ever going to have a time to have Parkinson's disease, now is the time to have it, not 5 years ago, not 10 years ago, not 50 years ago, because there are more treatments available now than ever before. There's more still under development. And this is the age where disease targeting or disease modifying treatments are being developed. And if those do show a benefit in clinical trials, and we hope they will, then they likely will help manage the cognitive symptoms as well, because the disease pathology for the motor symptoms is similar or identical to the disease pathology for the cognitive symptoms. So I think even within a patient's lifetime, a current patient's lifetime, there's reason to think that their treatment options will change in the coming years.
One of the things I think about quite a bit is, so we see folks with Parkinson's of all shapes and sizes, and sometimes I worry that, I want to be thorough and I want to make sure I'm asking about everything. But then I think when I quote unquote run the list of various non-motor symptoms, sometimes I worry that I'm almost planting the seed that they hear me asking about this. Oh, I guess that must be coming. And so, suppose I have a 60-year-old man and he has early mild tremor in his hand and he meets criteria for Parkinson's disease and he's taken some levodopa, but he's not really having non-motor symptoms and he's still working. Would you recommend routinely asking for patients, even a patient like this, about cognitive symptoms? Or what would you say in response to my concern about potentially planting the seed of symptoms that they may not get anytime soon?
I would say first is that I don't envy movement disorders neurologists because, as you already alluded to, you have so much to focus on. There's all the motor symptoms and their various iterations, and then all the non-motor symptoms. I can really just target my assessments and treatments to the specific areas I focus on, but you're not afforded that luxury. So I think it's just almost impossible within the constraints of a relatively short initial evaluation or follow-up visit to cover all of this territory anyway. That being said, I think in psychiatry, we're trained to not think that because we ask about something that it's going to cause a problem or cause somebody to become worse, that it's better to be upfront and open about things. And that includes things such as suicide ideation or death ideation, that we're taught to be kind of proactive about asking about it rather than being fearful about asking about it or worried. So I think that's maybe just part of, how we're trained. I do think, now that you've asked the question, I personally believe that every patient should be assessed for all of the common non-motor symptoms, or in my particular area, all the common psychiatric symptoms and cognitive symptoms from disease onset, and just make it a part of the routine assessment. So that would be depression, anxiety, psychosis, once treatment is initiated, impulse control disorders, apathy, and of course, cognitive abilities. So I think they should both be asked questions about it. If there's an informed other, I think that informed other should be asked questions about it, so you have good collateral information. And I think some kind of routine screening instrument should probably be administered annually. Now, that may be idealistic to say that, but I think you can make the case for it.
So suppose I'm seeing someone and she does express cognitive concerns, and I do some brief cognitive assessment, and I can tell that, their concerns are corroborated, and the types of symptoms they're described of a cognitive nature are fitting for what I would expect in someone with Parkinson's disease. How far do you go looking for some other cause, right? Because do you normally do brain imaging if everything is just fitting for typical Parkinson's disease, cognitive impairment? We're often thinking about things like vitamin B12 deficiency or thyroid disorders. I guess my question is, how aggressive are you looking for some other culprit if everything is seemingly pointing towards a neurodegenerative Parkinson's etiology?
I may be a little bit of a minority, or there may be just varying practices among geriatric psychiatrists or neurologists. So if I was seeing a general geriatric psychiatry patient and somebody presented with cognitive changes, particularly if they were acute or subacute, then I'd be more likely to do a full laboratory and maybe imaging workup. Because the people we're talking about already have an established disease, Parkinson's disease, where we know that cognitive changes can happen early on and can happen across multiple domains and can progress over time or have onset over time. I think I'm less likely to go and search another explanation, unless it, again, is more of an acute or subacute onset or something's dramatically different. So I typically don't, in a Parkinson's patient anyway, get things such as TSH or syphilis test or B12 levels. They're just rarely positive. And I don't know that structural imaging is very informative in terms of clarifying the diagnosis or leading you to a different management strategy. I would say that the one exception potentially, although this is brand new, would be the approval recently, the FDA approval of Alzheimer's disease biomarkers, LumaPulse, p-tau 217, A-beta 142 plasma ratio. So if you're treating a Parkinson's patient and you wonder, have some concern that they might have comorbid Alzheimer's disease, then you could reasonably order that test to see if they're, one of the minority, but not an insubstantial minority of Parkinson's patients that also has comorbid Alzheimer's disease. Whether that would impact your treatment or management at this point in time is hard to know.
Great. And so as a follow-up of that, for many of us in our different practices, we have different degrees of availability for, say, formal neuropsychological testing. And kind of as a follow-up to that, in what situations do you find it helpful? So I can imagine that scenario, someone with Parkinson's, they're really having memory recall issues, and you're not sure if it actually is Parkinson's or maybe it's something else going on at the same time. Neuropsych testing might help in that situation. Are there other situations where you find it especially useful? Sometimes when I'm talking to patients, I'll say, well, this can help serve as a baseline, or maybe if I don't think that their concerns actually reflect true progression of cognitive changes, and I think they're maybe one of these folks who's worried more so than they necessarily need to be, I can say, well, formal testing was reassuring. That can be a reassurance. When do you find it useful?
I think the situation you just outlined is a good one, and I do use it in that case. There's a lot of Parkinson's patients that are, relatively young at the time of disease onset. I always like to remember, and I think it's not something we necessarily keep in our mind, but the average age of onset for Parkinson's disease is probably in the low 60s in the United States anyway. The average age of onset for Alzheimer's disease is in the low 70s. maybe. So you're talking about almost a decade difference, possibly. So what does that mean? That means that many of these Parkinson's patients are still working, maybe raising families. They have a lot of responsibilities still. So those are people that tend to worry more about the impact of cognition on their day-to-day life because of those responsibilities. So I think in that case, somebody who's noticed some mild changes or is very anxious, I think anxiety drives some of this as well, which is also common in Parkinson's. I think it is sometimes helpful to have the additional results you get from detailed cognitive testing. So instead of doing something that we all commonly do, like the Montreal Cognitive Assessment, which takes about 10 minutes, the MoCA as it's called, you're instead doing maybe 1 to 2 hours of detailed cognitive testing. I think the other advantage of the detailed testing is it's probably more reflective or accurate or stable. We know that MoCA scores can fluctuate pretty wildly. So just because you had a bad MoCA test on one day, it might be kind of alarming to someone, or we may make some assumptions about that person based on that. But if you retest them even days later, a week later, you might get a different result. I think that's less likely to happen with the detailed cognitive testing. And I'd say the other place, as you know, where this is commonly used, the detailed cognitive testing, which is really part and parcel of most neurology clinics now, Parkinson's disease centers, is for people being evaluated for deep brain stimulation, because we've just have enough research now to know that for people who have significant cognitive impairment going into brain surgery, they're more likely to have a difficult course afterward, worse cognition. So we really do try to get detailed testing as part of the DBS evaluation to make sure that we're safe having the patient go through neurosurgery.
Terrific. And one more question here. I didn't spend too much time preparing to talk about treatment of cognitive impairment in folks with Parkinson's disease. But when I was refreshing myself, other than the cholinesterase inhibitors, which we know of, I was reminded about the fact that some folks use different stimulants to help with attention. And that's something I don't think of a whole lot. I was curious, is that something that you use frequently or find helpful?
We really have quite limited treatments for cognitive impairment, whether you're talking about the stage of mild cognitive impairment or at the more severe stage, dementia. There's only one FDA-approved treatment for dementia or any cognitive impairment in Parkinson's disease, and that is a cholinesterase inhibitor, rivastigmine, for Parkinson's dementia. So this is really a big unmet need, given how common and bothersome or upsetting this is to patients. I will say that this is a very active area of research. There's a lot of pharmaceutical companies or biotech companies that are very interested in the cognitive space in Parkinson's disease. So I'm hopeful that in the coming years, we're going to see some more positive trials, both within PD and its sister condition, dementia with Lewy bodies. So I do use cholinesterase inhibitors, even sometimes in patients with milder cognitive changes, and certainly through to more severe cognitive changes. I think the evidence for memantine, which is a NMDA antagonist, is not compelling for Parkinson's disease dementia, so I use that less commonly. In terms of purely attention deficits, I do use medications that have stimulating properties sometimes. So there's a couple of medications that fall into that class. There's pure stimulants like amphetamine or dextroamphetamine. There's medications that are used for attention deficit disorder that are stimulant-like, methylphenidate. There's actually, a poor man's version of this that I use clinically is an antidepressant, bupropion, or Wellbutrin as it's also known, because bupropion is structurally related to stimulants, so it tends to have stimulating properties. And then finally, I'd say the other medication I occasionally use is the noradrenergic reuptake inhibitor, amoxetine. It's a selective noradrenergic reuptake inhibitor. It's FDA approved for the treatment of attention deficit disorder, again, because attention deficits are common in Parkinson's disease.
Great. Any other thoughts you have or clinical scenarios that you encounter that you think are useful for us to be thinking about?
Well, I do try to remember that the treatment options are limited currently. So are there ways you can work around the margins, as that expression goes, to help a Parkinson's patient perhaps preserve their cognition for as long as possible? Now, we don't necessarily have high quality evidence to support these steps that I'm going to mention. Most of them are relatively easy to implement and not come with any risk associated with them. So it's hard not to recommend them until we have something better to recommend. So I would say that cholinesterase inhibitors are underutilized overall. I mentioned that already. I think there's probably a role for physical and cognitive exercise, which I think many Parkinson's patients are on board with. And whether that makes a long-term difference in terms of their cognitive abilities, it's hard to know. But there is evidence both within Parkinson's and outside of Parkinson's disease that cognitive exercise and physical exercise may have benefits in terms of cognition. We think that socialization is very important, that people that tend to be loners or isolative tend to do worse cognitively over time. So that's another recommendation to be made. I always take a look at the full medication list when I'm seeing a patient, and the medications I'm on the lookout for are those with anticholinergic properties, and that can include common over-the-counter sleeping medications like Benadryl or diphenhydramine. So anything with anticholinergic properties can potentially worsen cognition. I'm mindful of working with a neurologist. I don't prescribe the Parkinson's medications myself, but looking at their Parkinson's list, patients often end up on multiple medications. They may end up on medications at higher doses. And certainly patients can become more confused on higher dosages of levodopa equivalent dosages. So I have the neurologist at least reevaluate the need for all of the medications or at the doses are being prescribed. Treating comorbid vascular diseases is very important. So we know that Parkinson's patients are not immune from having things such as high blood pressure, diabetes, hypercholesterolemia, obesity. All of those things can contribute to cognitive impairment. So if they're managed better, then that's one less thing for the Parkinson's patients to worry about. I feel like I'm coming up with a long list here, but there are just a couple more that I think are important. There's some evidence that psychiatric conditions such as depression can worsen cognition in Parkinson's disease long term. So treating depression, whether it's with antidepressant medication or counseling, I think is important. And then finally, two specific comorbid conditions associated with worse cognition in Parkinson's disease are orthostatic hypotension. So patients with orthostatic hypotension have worse cognitive performance when they go from a sitting to a standing position and their blood pressure drops. And also obstructive sleep apnea. So people that have diagnosed obstructive sleep apnea that don't use a CPAP machine or other treatment for their sleep apnea have worse cognition than people that are treated with obstructive sleep apnea. And this is a relatively common comorbid condition within Parkinson's disease.
I'm surprised how many times I find that when patients are experiencing orthostatic hypotension, that once that gets better regulated and their blood pressure is doing better, they oftentimes come back and say, I'm thinking more clearly. And it's not surprising. I mean, I tell them, well, you weren't getting enough blood to your brain, right? And so if we're not getting enough blood to our brain, we're going to have some cognitive symptoms. So that's one I often encounter in clinic.
I agree.
Well, Dan, I really appreciate you sharing your thoughtfulness and your expertise with us today. I find this very useful to think about and check out. Again, this paper that we mentioned at the start, it was published in August 2024, the Green Journal of Neurology. It was titled Long-Term Dementia Risk in Parkinson's Disease. And also, Dan did a podcast with Jeff in August of 2024 that you want to check out as well. Dan, thank you so much. We really appreciate it.
You're welcome, and thank you for the invitation, Jason.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.